All of you to this live program at Orthopedic Principles. Today, our guest of honor is Professor William Levine from New York, United States. Dr. William Levine is a Frank Stinchfield Professor and Chairman at the Department of Orthopedic Surgery at the Columbia University College of Physicians and Surgeons and Orthopedic Surgeon-in-Chief at the New York Presbyterian Columbia University Medical Center. Dr. Levine is an internationally renowned shoulder and elbow surgeon. He is a past president of the American Shoulder and Elbow Society and has dedicated his career to patient care, education, research, mentorship, and allyship. If you've noticed, Professor Levine has already delivered a lecture on a channel and also already reached a huge audience. And today is my great honor to bring back Professor William Levine for this wonderful live program. Over to you, Professor.
Well, thank you so much for having me. It's great to see you again. And I hope that we can share some thoughts on shoulder arthroplasty, current concepts, as we discussed this morning. This is my disclosure. I do have a conflict of interest with Zimmer Biomet, and you can see the rest of my disclosure there. So whenever I think about a topic, I always like to understand the history so we can understand where we've come from. I'm going to talk about 6 innovation eras to kind of explain how we've gotten to where we are. And then I'll end with this very provocative line that says, don't throw away the anatomic total shoulder, because despite what you hear from podiums around the world, the reverse shoulder is awesome, but it is not without complications, and the anatomic is a fantastic option for many of our patients. So although Payan from France is often given credit, it was actually a German physician and surgeon, Gluck, who created the first shoulder arthroplasty. He was a pioneer of joint replacements, including shoulders, and it was made out of interchangeable ivory ends. It was actually a modular prosthesis, and he was set to present the skeleton of Paris to the German Scientific Congress in 1890, but they shut him down, so it never made it. So Payan does get the credit for the first shoulder replacement. The patient was a 37-year-old with tuberculous arthritis, had a large abscess. It was a 2-stage procedure. The first stage was the resection of the proximal humerus. The second stage was done in 1983 at the International Hospital of Paris. You can see the implant, which is currently in the Smithsonian. It was made out of iridescent platinum, had a hardened rubber ball with grooves and 2 metal loops. And unfortunately, of course, there was no antibiotics, and the patient got infected, and it ended up having to be removed. But this was indeed the first shoulder arthroplasty. We really didn't have a lot going on in the shoulder. In the 1930s, this comment was, there are no fractures in which prognosis for recovery of function is more grave than those about the surgical neck of the humerus. And so we recommended humeral head resection versus arthrodesis because they just didn't have a good way to fix fractures. We then go to the 1950s with the Baron Judet prosthesis and the Dianquin in Argentina. It was acrylic so that it actually fractured. It was not very sturdy and had lots of dissociations. So we really, you think about it, we went from the late 1800s all the way to 1950s and 1960s without much progress in the world of shoulder arthroplasty. And then we get to this guy, Dr. Charles Neer, the pioneer of shoulder, the patriarch of shoulder surgery here at Columbia, was on the famed New York Orthopedic Hospital fracture service, where there wasn't really that much orthopedics, but it was trauma and fractures in the beginning. And he started playing around with how can we deal with this proximal humerus fracture. He came out with this Vitalium humeral head replacement with a long stem designed for fracture use. And that really was the forerunner to the rest of his arthroplasty systems, including fixed fulcrum designs and the Neer 2 system. The Neer 1 was a monoblock. It was, again, a fracture prosthesis, had a 44-millimeter head radius. It was designed to be press fit and had multiple stem design diameters. And there was no glenoid at this point because this was just for fractures. And then he started to use that for arthritis. And Dr. Neer noted good but not outstanding results. He still had a fair number of people that had discomfort, had fatigue, and he thought maybe they could do something on the glenoid side to try to address that. A group out of the UK actually predated Dr. Neer, although they don't get as much credit, by implementing the first total shoulder arthroplasty system. And then the second generation really was modularity. And this is where we started to be able to not have a fixed humeral implant and change the head size, change the head height. And that led to improved opportunities for us as surgeons. Third generation was really dramatically disruptive. This was where we could now change the version and inclination, led by Gilles Walsh and Pascal Boileau in France. The fourth generation was convertible. Could we put a stem in on the humeral side for an anatomic and truly have it be convertible to a reverse? We'll talk more about that in a moment. And then the fifth generation was stemless, and a number of stemless designs from around the world were implemented to try to decrease bone loss and perhaps make it a simpler operation. So if you think about the eras, innovation one was the 1940s to the 1990s. We'll call that the near era. And that was hemiarthroplasty and total shoulder arthroplasty. And was this disruptive innovation? It sure was. This totally changed the playing field for what we had to offer our patients. Well, a number of studies over the years have shown superiority of total shoulder compared to hemiarthroplasty in patient outcomes, durability, and patient satisfaction. Innovation two may have been the most disruptive of all, and this was the Grammont era from 1983 to currently, and really an amazingly disruptive innovation that changed our ability to help patients. And the problem was this: we had all these constrained designs. Near designed one, it was the Mark I, then the Mark II, the Mark III. And if you look at them, they all kind of looked like total hip replacements with very lateralized centers of rotation, very poor fixation on the glenoid side, often fixed with cement, and the failure rate was remarkably high. The Mark II, the Mark III, all of them abandoned, and Near really said, this is a problem I can't solve, and we therefore should just give up on it. And that's kind of what the world did. And so you had all sorts of really, really bad ideas and bad prostheses from around the world that all did very poorly. And so then and this was the problem we faced in real life, of course, is that the patients had catastrophic pseudoparalytic shoulders for which we had no solution. Then came along Paul Grammont in 1985 in a small town in France, very creative, innovative guy. And he said, you know what? I don't believe that there's nothing we can do. And he kind of modified a bunch of designs. He had some failures along the way, but he came up with that picture you see on the left as a new option. And what did he do? He medialized the center of rotation. He changed the neck shaft angle, and that helped to increase the deltoid lever arm. He made the center of rotation at the glenoid bone implant interface to decrease shear forces. And he was able to retension the deltoid by humeral distalization and allow the deltoid to raise that pseudoparalytic shoulder again. And he created stability by making it a semi-constrained implant. So this was the original design in 85, and this was the commercially available one that came out in 1991, first with Depew and then later with Tournier. And so again, the two distinct changes: decreased to a half sphere with medialized center rotation, and the glenoid was press fit with peripheral screws. So taking advantage of the good bone and not relying on cement. And so the innovation here was amazing. It caused us to be able to, allowed us to be able to treat pseudoparalytic shoulders as seen in this 78-year-old woman with a dramatic response. It was stable for the most part and reliable, but there were concerns. It caused scapular notching, osteolysis caused of the glenoid, the humerus, polyethylene wear, and that led to tuberosity resorption and profound humeral bone loss. It led to poor improvement in external rotation because of the medialized center of rotation, also leading to insufficient internal rotation. There was the concern of instability, especially with proximal humeral bone loss, and of course the ever-present loss of shoulder contour with the original very distalized, medialized Grammont style prostheses. That led to Mark Frankel, who actually in 1998 started to say, I don't believe the French have this exactly right. I think that there's a balance between the poor lateralized designs and the very medialized Grammont design. And he went through his own 6 iterations to come up with what is currently available by Innovus. So Mark really deserves tremendous credit for changing the playing field and saying, no, I think we can be more lateralized. That'll decrease scapular notching. That will improve rotation. That will improve function. That will improve patient-reported outcomes. That's exactly what he set out to do. So if you look at the timeline around the world, Tournier came out in 2004, Zimmer, then Exactech, and then, of course, now the explosion of implants from around the world from many countries and many companies. And this is the fastest growing arthroplasty industry. So if you look back at Payan in 1983 and now all the way out to 2025, dramatic changes in the industry. And one of the questions that we asked in our design prosthesis of the identity is the prosthesis really convertible? And does convertibility matter? Well, a number of studies would suggest it does. This is a study from 2023 with a convertible stem, and they found that 49% of the time they had to revise the humeral component even though it was convertible. That led to decreased outcomes, increased blood loss, and increased OR time. Christian Gerber showed with the convertible stem that if it's not convertible, you have increased blood loss with stem exchange, and you have increased surgical time. Now that's kind of an annoyance, but this is really concerning. Look at the amount of complex stem exchange. Those are significant complications that really increase the complexity and potentially decrease the outcome for patients. The Dutch registry again looked at this, and these are convertible stems, and the stem had to be revised in 42% of cases, 28% of the time unplanned. So even if you're using a convertible system, it may in fact not be convertible. So our thought was, let's create a system where the humeral prosthesis is placed 5 millimeters below the osteotomy line so that if it's an anatomic, you can easily convert it to a reverse. And that's exactly what we've shown since this was released in 2022 in North America. It was just released in Europe in October of this year, and the first one performed in Barcelona last month by Doctors Joseph Aboud and Olivier Verbeau. So now available in Europe. Is it just marketing? No, I don't think so. Revision arthroplasty is increasing 392%, and instability is not benign. So having a prosthesis that you can convert from anatomic to reverse, I think is really important. Innovation 3, pre-op virtual surgery, really critical. All of the companies have a surgical planning software program. Understand the program. Some are manually segmented, some are automatically segmented, and that can lead to differences and errors, but just understand the system you're using so that hopefully you're getting the maximal utility from it. This is definitely disruptive innovation. And has it changed what we do? It sure has. We now get 100% CT scans and pre-op virtual surgical planning. Is that necessary for all patients? Probably not. But in the training situation with residents and fellows, medical students, young faculty, we have found it to be very educational and helpful for us in thinking about that surgical plan. Correct. Innovation 4 are custom implants. So this is patient-specific instrumentation, as shown here, patient matching by Stryker Tournier, and the custom reverse total shoulder with the VRS, with Lima, and several other systems on the market. So this is when either you have a severe deformity that you really don't want to use off-the-shelf implants by themselves. You feel like you want to have a patient-specific instrumentation to make sure that base plate is placed in the correct position, as shown in this video. Or there's so much catastrophic bone loss that, frankly, an off-the-shelf implant will not be possible, and therefore we need a custom base plate. So is this disruptive innovation? Yes, of course. And then intraoperative execution of the plan. Exactech has led the way in this regard. This is courtesy of Howard Routman. As you can see here, they place a tracker on the coracoid process, as you can see, and then you can see in real time the execution of your plan, not just the plan up on the computer screen. And so I think that is something that has been used now for many years with the Exactech system, and other systems are coming down the road. So I think this is definitely innovative as well. Stryker now using mixed reality, augmented reality. Other companies likewise trying to take what we do preoperatively with a CAT scan and trying to implement that into the actual surgery for our patients. Innovation number 6. Well, this is robotics. Zimmer Biomet was the first with the ROSA. Now there are others close behind. And the question is, will this move the needle? And I think right now it's safe to say that robotics clearly are accurate. There's no question their accuracy is phenomenal. But I don't think we're quite at the point where we're ready to implement it across the board. Even in the knee, where it's been around for a while, it's been hard to demonstrate that patient-reported outcomes are improved or that quality of outcomes are improved. It may be that we're just not asking the right questions and we aren't sensitive yet enough to know exactly what to ask. But I think that it's safe to say that robotics will likely be a part of the future with all of the time, energy, and cost that's gone into it, but that right now we're still figuring out the best way to implement it in the operating room without compromising your flow, without impacting the normal rhythm that you have as a surgeon in performing the operation. What's new? Well, it's not that new, but pyrocarbon is something that's gotten a lot of attention really recently. Pyrotitan was the first pyrocarbon striker. And why pyrocarbon? Well, it's up to 300 times less wear on bone than zirconia and medical grade metals. So it's been around a while. You can see the X-ray on the right. With the current system by Stryker, you have to have that additional metal plate that the humeral head sits on. And that has been a point of consternation for many surgeons where the final outcome looks to be overstuffed and maybe causing additional problems. A recent systematic review looking at pyrocarbon had promising clinical results, but a lot of caution. Minimum 2-year follow-up, 23% glenoid erosion, 10% implant position change, 10% tuberosity thinning, and 7.8, almost 8% revision rate. And this is only a 2-year follow-up. So as much enthusiasm as there is with the pyrocarbon, I would just voice some caution that I think that this is still, until proven otherwise, just the latest and greatest hemiarthroplasty with all of the problems that we know hemiarthroplasty has historically had compared to anatomic total shoulder arthroplasty or compared to reverse total shoulder arthroplasty. So I don't think that the current iteration of the pyrocarbon is going to be the answer, but we'll have to wait and see. I do know it's very expensive to make. It's also very volatile in terms of danger in making the product. So I think there's not a lot of companies right now that are heavily investing in pyrocarbon. So I'm not sure what role it will have over the next 5 years. So is the anatomic total shoulder arthroplasty like the Velociraptor, like it's extinct, we shouldn't be doing it anymore? Or is it like Freddy Krueger and we can't kill it and it's just going to keep coming back because it's so good? So anatomic total shoulder, from my perspective, is an amazing procedure. Long-term outcomes are still terrific, but we have 2 major concerns: glenoid loosening and durability of the glenoid implant, and soft tissue problems. Subscapularis, we create that problem often by taking the subscap down, or the rotator cuff integrity decreases and wanes over time, and the patient becomes cuff deficient and therefore has problems because they have an anatomic. So the solutions to these problems can be looked at by the approach to total shoulder, by glenoid design, and by improving glenoid materials. And we'll cover those 3 options now. But remember, the long-term outcomes of anatomic total shoulder arthroplasty, as just shown anecdotally in these 3 videos, are far superior to hemiarthroplasty. And even when you compare a well-done anatomic to a well-done reverse, patients do tell you that they like the anatomic side better than the reverse. Not that reverses aren't terrific and can't get great results, but when push comes to shove, anatomics do outperform reverses. So glenoid loosening is a big concern. In this study from 2025, look at the huge study here, 35,000 procedures, and had 2744 failures. Implant loosening, 26%. 21.7% of the was out on the glenoid side. So a significant issue. Rotator cuff insufficiency, another 17%, instability and infection. So clearly glenoid loosening is something that we have to be very concerned about. In this study, 532 anatomic shoulder arthroplasties, 2003 to 2013, Philippe Valente in 2020. Again, cause of instability, subscap failure, and massive cuff problems. And you can see how soon or late that those problems occurred. Subscap failure is interesting. Not all of them need revision. In this study from John Levy, 668 patients, 34 failures, 5.1%. In the scapular dysfunction group, actually only 8 of 34 ended up requiring revision. So you don't always have to revise even when you document subscap failure. And remember, there's this rapid rise in reverses and in reverse complications. Acromial scapular spine fractures, as shown here, catastrophic bone loss when the glenoid base plate fails, as shown in this particular case. So George Athwal just published a study that everybody should put on their to-do list to read. This is a multi-center systematic review, 16 studies, 346 patients in 355 revised shoulders. The indications for revision of a reverse were instability, base plate complications, and infection for the most part. The overall complication rate for a revision reverse total shoulder arthroplasty after a complication from reverse total shoulder arthroplasty was 1 in 3. The revision rate was nearly 30%. This is not a benign operation, and it shouldn't be thought of it if, God forbid, it goes on to fail. So this is something to keep in mind as we see the rapidly increasing incidence of revisions and prevalence of reverses, and the rapidly growing indications for doing a reverse. So it used to be this was a salvage operation for cuff tear arthropathy with a pseudoparalytic shoulder. Now we have people up on the podium saying, I do it for all cuff intact osteoarthritic patients. I do it for all fractures. I do it for all patients. Had a surgeon the other day in Paris at a meeting proclaimed that he does 100% reverse shoulder replacements. And that's more of the common norm now than it is the exception. And I do find that to be alarming and concerning. And I think we should all be honest about what that potentially means for our patients. So let's talk about solutions, surgical approaches, glenoid designs, glenoid materials. On the approach side, subscap splitting and posterior. On the glenoid design side, we'll talk about the transition from all poly to metal back to hybrid. And on glenoid materials, we'll talk about implementation of vitamin E in our currently available prostheses. So if you think about from a surgical approach, subscap sparing has been around since 2009. Laurent Lafosse described through a rotator interval approach. Buddy Savoie described the inferior trap door, as shown in number A and B. Mike Ryway, my former fellow, who's now in Cincinnati, has described a posterior approach, which has been quite innovative and helpful in his hands. And Mark Mile from Tampa described a double window approach, but everybody trying to do the same thing. Can we do a shoulder replacement, but respect the subscapularis and respect the rest of the rotator cuff? And that's been kind of the search for the Holy Grail. This is what it looks like in the OR subscap sparing approach. You separate out the proximal 2/3 from the distal 1/3. You then flip the proximal 2/3 up and over the top of the humerus, and the exposure actually can be quite good, as shown here. Now we're going to dislocate, and you see that lower 1/3 of the subscap after the surgery's been performed, and then it's simply just using suture anchors to repair the subscap inferior tag back to its anatomic insertion, and then do side-to-side sutures between the inferior flap and the proximal flap. So if the tendon doesn't get avulsed, the proximal 2/3, which is a complication and risk of this, it's an elegant operation and one in which you can address all the osteophytes. You're not doing it from the rotator interval where you can't see inferiorly, and it can be quite effective. The posterior approach, as I mentioned, Mike Ryway published in 2021 on 26 shoulders. He's now done close to 200. And he did find some issues of malpositioning, so that was part of his learning curve. He only had 2 complications, however, and overall has been a big fan. And you can see that's a cadaveric picture, but showing the incredible exposure that one can get with a posterior approach to the glenohumeral joint. What about glenoid design? Well, there's been a tremendous amount of research and development. We started with the all poly, of course, KEG, and then all keel, then the all poly PEG. We then went to metal backed, and that was not a good era for us. That was about as bad overall as lateralized reverse shoulders. They failed miserably. The poly was often thinner than normal, a tremendous amount of metal debris, and of high rates of failure. And then the hybrid design, I would argue, is actually a game changer. It's not metal backed, and so sometimes people get confused or get anxious because they've had a bad experience with metal backed. But this is a trabecular metal center post that allows bone ingrowth, surrounded by 3 traditional poly posts that are cemented in situ. The metal back glenoid has been a disaster. This study in 2024 showed a 9 times higher risk of revision compared to an all poly glenoid. And again, not all hybrid fixation is equivalent. Make sure you appreciate the company you're using or the implant you're using. The one on the left is an all poly center peg. The one in the middle is the TM peg, and you can see the cage type design on the far right with also metal peripheral pegs. This is a study by Joe Iannotti that showed central peg osteolysis and significant progression associated with clinical failure. Again, can you really envision that bone will heal into plastic? No, that's not what's going to happen. And so I don't think we should fool ourselves and think that that's going to be the case. So I think there's a real case to be made by having a center peg that allows bone ingrowth. And we've seen phenomenal long-term and midterm results in a number of studies, both commercially biased, if you will, international, multi-center, but they all show the same thing. 1 to 2% failure rate now at 10 years follow-up with Tim Cott's study, 2.5% revision from a systematic review, multi-center study, 99.6%, and an international study of only 1.1% glenoid complications. So from my perspective, I believe we have actually solved the problem of glenoid loosening, and using a hybrid glenoid with bone ingrowth on the center peg, to me, is the gold standard today. Finally, glenoid materials. Vitamin E is a natural antioxidant. It binds to free radicals in polyethylene. It helps to stop the oxidation cascade without, critically importantly, without decreasing the mechanical properties. Randomized controlled trial with vitamin E poly in the hip showed that looking at highly cross-linked poly plus vitamin E versus those without, and showed decreased wear, less femoral head penetration, distribution of wear was more even, and no osteolysis with the vitamin E impregnated polyethylene. An in vitro study showed that the vitamin E enhanced poly had decreased osteolytic and particulate debris and improved pristine properties. And so vitamin E is now used in Vivacity in the Zimmer Biomet family of prostheses. It's got exceptional wear resistance, long-term oxidative stability, and increased strength. So far, we've been very pleased with poly and have not seen any poly failures in the 3 years since its release in North America. I'm going to just finish up with a few cases. This is a 68-year-old right-hand dominant male, has 2 years of severe pain. He's failed non-operative treatment, including a cortisone steroid injection 1 year ago. He has very poor range of motion, and you can see his x-rays show advanced osteoarthritis, some level of medialization, but not terrible. The glenoid doesn't look like it's got too much eccentricity on these plain x-rays, but we know we need our CAT scan to best review that. So here you see the surgical planning software program. He had 5 degrees of glenoid retroversion, 1 degree of glenoid inclination. So nothing serious there, nothing that would warrant an augmented glenoid perhaps. And you can see the rest of the metrics. So you have the options. Do you want to do a pyrocarbon, an anatomic, a reverse, a bio-RSA? So what would you do? Well, this is what I did. I did an anatomic total shoulder with a short stem identity humerus and an Alliance TM hybrid glenoid. This is what he looks like 2 years post-operatively. He has fantastic range of motion, no pain, no limitations. He's back to playing all sports, including golf and pickleball, and he did approve the use of this video. Here's a tougher case, a 58-year-old male. He's 6'5", weighs 285, with a very large guy, left shoulder pain for about 5 years. He's failed all non-operative management, including viscosupplementation used off-use or off-label in the shoulder. He's had cortisone injections. He's modified his activities. He is miserable, and he's got very poor motion, but good strength. So here's his CAT scan. You can see his coronal view on the left and his axial view on the right. And here's our signature one planning. We always plan for both anatomic and reverse, just in case, especially if we are planning to do the anatomic. We can see what our planned stem size is with the identity system. We think we can see the head size. We can see where we're dialing the head with the VersaDial, and we can see what the cut thickness is. And then we can look over at the glenoid side and identify, okay, it looks like it's a size 5. It's an augmented, it's modular, it's got 4 pegs, etc. And so what did we do here? Again, we did an anatomic total shoulder arthroplasty. I did use a standard stem, which is 80 millimeters. There's really no difference between 55 and 80, to be perfectly honest. And this is what he looks like about 4 months post-operatively. Had an anatomic total shoulder as shown, and had an augment hybrid glenoid because of the increased glenoid retroversion. You can see he's regained his external rotation already in a very short period of time. And here's his internal rotation, which is always the hardest, but actually not too bad given where he started. This is an 83-year-old female, had 3-year history of right shoulder pain, failed non-operative management. Again, poor motion, has decided she can't live with it, has normal cuff strength. Here's the CAT scan. Again, shows a well-centered humeral head on both true AP and axillary views, but with advanced osteoarthritic changes, of course, and some cysts in the humeral head. You can see the 3D reconstruction with glenoid subtraction, with humeral subtraction on the far right, without any significant deformity. Here's our signature planning, and just a little video to kind of show how we can look on the computer and say, okay, do I need an augment? Do I need a non-augment? What size gives me, that 90+% backside contact? Ideally, you want it as close to 100 as you can, but you don't want to compromise how much bone medially you take to get there. So you have to be very cognizant and aware of how much bone you're actually taking. So now you've had the surgical plan on the humeral side. We can see the humeral head and where we're dialing in with our VersaDial system. And then, of course, we're going to use that as a template, but we'll make our final decision intraoperatively. This is the same patient's reverse planning, just in case that we think the subscap is compromised or the cuff is compromised, and therefore would go to a reverse in the same setting. So anybody that gets an anatomic replacement by me gets consented for possible reverse just in case. And here again, you can see that we're taking the glenosphere, we're spinning it around and showing it to give us the best overhang. So what did we do here? In this case, we again did an anatomic total shoulder. Patient was older, but had great subscap, had great posterior superior cuff. And so I did not hesitate to do an anatomic total shoulder replacement. But here's a good example of a 71-year-old female. Again, severe pain, looks like the last patient, maybe a little bit more inflammatory in nature, but can't live with it. You can see the CAT scan series showing the coronal oblique views, the axial views, and then our pre-op planning on the total shoulder side. We're going to put in a humeral implant of about 6 millimeters. We're going to look at the head size. That looks a little big at 42 by 18. So we're going to downsize that to a 39 by 14. And that looks like that might be a better fit for this patient. Don't forget that's inferior humeral osteophyte as well. So you want to remove that so you're not being fooled. Here we're looking at the glenoid and we're seeing 97% backside contact. And then we can look at the range of motion evaluation of our final construct and say, does that make sense? Does that look like that's a good plan? And sign off on it if it does. But before we finish, we're going to do a reverse planning because, again, every anatomic plan, I'm going to always plan in reverse because you just never know what the cuff integrity is going to be like. We're looking here. So far, our implant contact is only at 90. Well, what can we do to get it to 95%, 98%? Can we rotate it a little bit, take a little bit of bone, and can we get to 100% contact within the confines of what our parameters are? And the answer here was a definitive yes. So that looked great. So what did I do here? Well, the plan was to do an anatomic total shoulder, but you can't always do that. And this was one of those cases that the subscap was not of good quality. The posterior superior cuff was not of good quality. And so I did go ahead and do a reverse total shoulder with a comprehensive metal augment. So in summary, we've covered a lot of material, but anatomic total shoulder is a terrific operation. Surgical approaches to the decrease of the subscap and cuff failure are currently being explored worldwide. Glenoid loosening has pretty much been addressed with the hybrid designs, and I'm very comfortable saying that at this point. Glenoid properties improved with vitamin E enhancement. And remember that the reverse complications are not benign or on the rise. And for all the young surgeons out there, are something you're going to have to come up with a solution to avoid a catastrophic epidemic of reverse failures. So question, is the anatomic total shoulder extinct like the velociraptor, or is it coming back like Freddy Krueger? I would say there's still hope for the anatomic total shoulder. The future, disease modification, less surgery. Will the reverse be the 8-track tape of our generation? Artificial intelligence, machine learning, obviously changing the playing field very rapidly. Robotics, and then all of the enhanced reality. Mixed reality, immersive reality, augmented reality, all will probably play a part. Will a stemless reverse shoulder replacement be part of the future? I don't know. There's certainly been some success in Europe with the tests, but there's been lots of failures around the world. There's been lots of failures in North America with a couple of studies that had to be aborted. So we're still looking, but I'm not sure we're that close yet to having a suitable answer for stemless reverse total shoulder. So I've tried to review the history for you today, Hitesh. We've gone over 6 innovation eras, and the summary is don't throw away the anatomic total shoulder quite yet. Those are my 2 beautiful daughters, as I always show in every talk I've given for the last 20-something years. And thanks very much for your attention. I'll stop sharing and happy
Thank you
to
so
ask.
much, Prof. Thank you so much, Prof. It's always great to listen to your talk. And then by the end of the year, I think last year we talked about shoulder instability, and this year it's shoulder arthroplasty. And let's see what's going to happen next year.
Rotator cuff or fractures or whatever your
Yeah,
audience
great.
wants to hear about.
And I remember that last year the take home was to have a backup plan. So let's see what we can carry to the audience. And Prof, a few questions. Prof, you mentioned about the convertible prosthesis, right? Joe Abboud, he did this. Interestingly, I hosted Joe Abboud for another program. And what you meant, it's a revision situation, right? If you're moving from anatomic, in a situation of a primary anatomic, you want to revise it, you do a convertible, right?
Yes.
So what is the difference with the existing option? We already do a reverse, right? Even when you do a convention, if you want to do a revision, it's always the reverse, right? So what advantage does the convertible process give?
Well, if you're doing an anatomic prosthesis and you are using a convertible stem, but it's not convertible, and what I showed in the literature is up to 50% of the time, the stems on the market now actually aren't convertible because the stem's put in at the osteotomy site. And so if the stem is put in the osteotomy site for an anatomic, but now I have to put a tray on top of my anatomic, that's going to be too stiff and too tight, and I'm not going to be able to reduce it in many situations because it's a revision situation. So it's tighter to start with. There's more scar tissue contracture, etc. So if it's just simply not in the right place, then I have to remove the humeral component. If the humeral component's in the right place to start with, and all I have to do is remove the anatomic adapter in situ, then prepare the proximal humerus like I would for a primary reverse. Now we're cooking with gas and hopefully can do a very straightforward reverse. I can, if you want, I can show a quick video of that if that's of use to you, but if not, no problem.
No problem, Prof. We can do one more for the same stuff. And it's like the hip, right? In the hip, you have a similar situation. We can just revise the acetabular component, provided the femoral component is there, safe. Am I right?
Yeah, so if the humeral component's in the right spot, then you can revise it. And that's why we spent the last decade designing the identity system. And I've had to revise two anatomics that failed because of subscap failure following trauma. Both patients were doing great, but they had a fall within 6 to 12 months postoperatively. So I did have to revise two from anatomic to reverse. And it did exactly as we had hoped in the cadaver labs all those years. Both cases were 60-minute or less revisions from skin to skin, both on the glenoid side, where we took out the TM peg in a beautiful system and converted it to a comprehensive augment base plate. And on the humeral side, again, just remove the anatomic adapter and put in a tray and liner as if it were a primary reverse. So it really is advantageous as a surgeon to have that power to be able to pretty easily do a revision if necessary and not have to have 5 hours of sweating that I have to take out a humeral implant that's well fixed but in a terrible position, strut graft, cerclage, worry about radial nerve palsies, the things that Christian Gerber showed in the study that I referenced. So I think it's a huge advantage to not have to worry about all that and have a simple way to revise a failed anatomic to reverse if necessary.
Thank you, Prof. And Prof, just to recap the indications. Now, world over, like you mentioned, there's an exponential increase in the number of reverses being done, right? So the original indication was a cuff tear arthropathy, and now people are doing for almost everything, like fractures, massive cuff tears. And what is your take? Would you like to do a reverse in an elderly patient with a proximal humerus fracture?
Yeah, so
Or would you like
for
to
me,
retain the preserve it?
for the indications for reverse have definitely expanded, and I would maintain and propose to you that they've expanded too far in some situations. So, proximal humerus fractures in the elderly, 3 or 4 part proximal humerus fracture today, your best bet is to do a reverse. I don't think there's any question. Uh, Cuff tear arthropathy, no question. Massive cuff tear without arthritis, with full maintained forward elevation, be very wary about doing a reverse in that patient because they can be the unhappy patient because their postoperative motion is decreased compared to their preoperative motion. So if they have well maintained, a well balanced massive cuff tear with arthritis, but not that bad, it's not a cuff tear arthropathy patient where they're pseudoparalytic, they're painful. That's a patient that you can end up with a unhappy patient postoperatively. So be careful about that. The biggest controversy is cuff intact osteoarthritis. So now you have a straightforward osteoarthritis,
Primary arthritis.
primary osteoarthritic patient, 60 years of age, has end stage arthritis with an intact cuff. We have good friends of mine suggesting that a reverse is the procedure of choice for that patient, and I would respectfully disagree. And I think that we have reverses for reasons where there was cuff deficiency, cuff incompetence, cuff failure. The reverse was not designed specifically for cuff intact OA. And so I do think it leads to a different set of problems, complications, and issues that you would not face had you done a primary anatomic total shoulder arthroplasty given the same scenario.
In your practice, what is the percentage of people who have a primary glenohumeral arthritis? Is it less or maybe 50%?
That has, excuse me?
In your practice of shoulder arthroplasty, how many patients would actually fit into a primary glenohumeral arthritis where you want to do a anatomical total shoulder?
Oh, I have a huge number of patients that, I mean, I don't know what the exact percentage is, but, you know, yesterday in office hours, I saw, I think, 34 patients, and 8 of them were new patients with end stage primary osteoarthritis. So that was just in one day, one clinic. But that's not unusual. So at this point in my life, I have a tremendous referral pattern or referral practice of end-stage arthritic problems that get referred to me for consideration of shoulder arthroplasty.
So you'd be doing more of anatomic or reverse, which is predominant in your
Well,
practice?
my breakdown is variable based on the day. In general, we're at about 60% anatomic, 40% or 55-45 anatomic to reverse. It has come down, but I still do a lot of anatomics based on, and I don't base it on patient age. I don't base it on patient range of motion. I don't base it on, some of the things you hear about. I base it on the factors that are really going to influence the patient. Number one, do they have a centered humeral head for the most part on both coronal and axial images? Number two, do they have an intact and functioning rotator cuff? Number three, do they have a normal glenoid vault that will allow implantation of the TM peg for a hybrid design? And number five, what is the intraoperative assessment of the subscapularis quality, integrity, as well as the posterior superior cuff quality and integrity? So there's a lot that goes into that, but I think that's worth it because, again, as I stated, I still firmly believe, as do others, that a well-done anatomic will outperform a well-done reverse. The reverse has much more forgiveness. So for surgeons that do a handful a year, they're not doing 100 shoulder arthroplasties a year. It may make sense for them to do much more reverse than anatomic because the anatomic's harder to do. It's harder to get the same results perhaps, but again, I'll keep saying, if it does well, it's going to do better than a well done reverse. So that's
Nowadays, I think, yeah, we'll have fewer mentors who actually do the anatomic, right? Because I've hosted Prof. Matson, and he was a big proponent of anatomic.
Yes, and so but it's the same conversation you and I had a year ago. It's the same problem with an open Bankart procedure is that young trainees, young residents and fellows aren't even seeing the operation. So how could you expect them to do it? Of course they won't. So now you have residents and fellows leaving fellowships or residency programs not having seen anatomic shoulder arthroplasty. It's almost hard to even say those words, but that's the fact that there are some people, depending upon the biases of their mentors, who aren't even being exposed to this extremely elegant operation that has, stood the test of time since Neer's first implantation in the late 1960s. So that's a shame. And as we see the dramatic rapid rise in complications of reverses, and some of those complications mean that you will never, ever, ever, ever get a good result, scapular spine fractures, catastrophic bone loss, etc., we should be wary. We should be very wary about the wholesale change to an operation without a full understanding of what the implications are for society and what the implications are for our individual patients who are going to suffer because they didn't have an anatomic put in, but they were forced to have a reverse and then have a scapular spine fracture or what have you.
And Professor, as part of your training to residents, do you use virtual reality? Because now there are so many companies like Precision OS. Some of them have come with the technology so that residents can train well and do the surgeries faster. So do you have it in your hospital? I remember a lot of hospitals in the US, HSS, they've all got the VR program.
Yeah, I would say that a lot of hospitals have it, but not a lot of hospitals use it. So I think we published a beautiful study in JBJS. Bill Crockett, one of my senior residents, did a beautiful study looking at Precision OS specifically. And one group of everybody got a lecture, and then one group of residents had hands-on, and one group of residents had VR. And then I independently was blinded and watched them do a cadaveric reverse shoulder replacement and graded them on a series of intraoperative variables. And what we showed was that the virtual reality was good. It actually could supplant cadaver surgery, but it's not something yet that's really ready for prime time from my perspective. And the most important thing is, can we actually implement it in a meaningful way to help our surgical execution of our plan? And there's been a lot of work in that. George Athwal has done great work with Stryker, and others have been very involved with trying to do that. But I still think we have a ways to go from where we can put an oculus on our head and our eyes and then go do the procedure. My vision would be that we would eliminate irradiation, eliminate CAT scans, and have enough machine learning in our oculus to look at the deformity, understand what that deformity means compared to the thousands and thousands of shoulder data that have been input into it, and can say, yes, you need to put your center pin right there, and then start the preparation. So that's my kind of utopic hope for the future, is get rid of all these CAT scans, get rid of the irradiation. And I suspect we'll get there. And I think we'll get there faster than we think, because technology is moving so quickly right now.
Okay, Prof. Prof, I think that's all the questions that we have for the session. Thank you for this yet another fantastic talk. And this time, I think you should remember the anatomy before you actually start doing the reverse, and do enough preparation before you start doing the arthroplasties, right?
That's correct.
Thank you so much, Prof. And I think you're busy today. You have a great long day with a lot of meetings. Thank you so much for joining. And it's always a pleasure to listen to you.
Nice to see you. Thanks for having me.